On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Meredith Mayo. Dr. Mayo is orthopedic surgeon with fellowship training in both sports medicine and complex shoulder surgery. She graduated from the University of Pennsylvania and earned her Doctor of Medicine degree from Emory University School of Medicine in Atlanta, Georgia. She went on to complete her orthopedic surgery residency at the University of Colorado School of Medicine. She pursued advanced fellowship training at Stanford University in complex, minimally invasive knee and shoulder procedures, as well as shoulder replacement surgery. During that time, she took care of the San Francisco 49ers, members of the U.S. Women's National Soccer Team, and NCAA national champions. She sees patients at Boulder Center for Orthopedics and Spine in both Boulder and Lafayette. Welcome, Dr. Mayo.
Good evening. I'm Meredith Mayo. Thank you for joining us this evening. Thanks, Karen, for that introduction. And we're just going to pull up our slides here and get started. All right, so I'd like to kind of summarize and outline the discussion for the evening. It will guide us throughout the next about 45 minutes of conversation. And if you look at this slide, anything that's bold really includes the sections that I'll review, and this is the order in which I'll review them. The subject of arthritis for any joint in the body is a little bit complex to just jump into without further explanation. So the first two sections are really more of an anatomy and biomechanic review of how arthritis can be impacted. Initially, as we review relevant shoulder anatomy, we'll discuss both bony components of what shoulder anatomy entails, as well as the surrounding musculature, which can have an impact on shoulder arthritis, one form in particular. Additionally, I'll review what arthritis is on more of a biomechanic scale in terms of how the joint lining can start to wear down and the subsequent effects that can have on each joint. Next, we'll discuss how arthritis affects the shoulder in particular. After we review that, we'll go through a little bit about what conservative treatment options there are for shoulder arthritis. We'll also review next procedural options for shoulder arthritis. And lastly, we'll get into what shoulder replacement includes. So to review some general but important points about the shoulder joint itself. The shoulder joint, which is depicted here on this image on the right, is a ball and socket joint. The ball is formed by the proximal or upper end of the humerus bone, which is the upper arm bone. And the socket is actually formed by a projection of the shoulder blade. And together they function as a ball and socket. This also creates the most mobile joint in the body, meaning you have the most degrees of freedom or range of motion. I'm not sure if people have thought about that before, but the shoulder is a much less constrained joint from a bony perspective than any other joint in our body. Due to that minimal bony constraint, what we have is very important surrounding musculature. You can see on this slide that glenohumeral is outlined in red. What that represents is the name for the actual shoulder joint. So we'll see future slides where I reference glenohumeral, and that refers to the shoulder joint itself. Next, this slide is very busy, and I'm certainly not going to go through all of it. The main point of this slide is to look at the muscles of the shoulder when you're looking from the front or anterior perspective. The left portion of the image shows the more superficial or outer layer of muscles. You can see it almost looks like a fan with major muscles going across your chest and your outer arm. If you look at the portion of the image on the right where the muscles seem smaller, those are the deeper muscles that are directly over the glenohumeral or shoulder joint. The one that I've outlined in red on this page is a very important muscle. It's called the subscapularis muscle. It's one of the 4 rotator cuff muscles. We'll talk more about that later. If we go to this image, the concept is the same, except now we're looking at the musculature from the back. So in this image, again on the left, you can see these larger muscle groups that are going over the shoulder joint, connecting to the shoulder blade in particular. And this is very important to comprehend because a lot of shoulder pain is actually related to shoulder blade dysfunction and shoulder blade pain. Additionally, if you look at the top of the left of the image, you have muscles going from the shoulder blade all the way up to the base of your skull and along your cervical spine or your neck. And those muscles can become very inflamed with shoulder arthritis and present with pain in the back of your shoulder, even along your back. If we look at the right portion of this image, the main thing I want to focus on here, again, these are the smaller, deeper muscles in the posterior or back part of the shoulder, are the three that are outlined in red. Those three make up the remaining four of the rotator cuff muscles. And again, they are very important as we start to discuss shoulder arthritis. Collectively, the rotator cuff is the set of muscles that allows you to rotate your arm and lift your arm away from your body. Their integrity or attachment is also very important for some of the surgical options and interventional options we'll review later. So now that we've had this bit of review of anatomy, and very simple, but hopefully we hit the key points, I want to discuss a little bit about what arthritis actually is. So again, on the left, what we see is a nice depiction of what the normal glenohumeral or shoulder joint looks like. You can see at the top of the humeral head or ball and on the socket side that you have this white layer. I tell people in the office it looks like shiny, bright, white, smooth, dense tissue like a cue ball if you were playing pool. That is normal cartilage. What happens throughout the stages of arthritis is the cartilage initially becomes soft, but still maintains its thickness, and then you start to lose thickness of the cartilage. Ultimately, you can erode away all of the cartilage and expose the bone beneath the cartilage. When that happens on both sides, you probably frequently heard terms like bone-on-bone arthritis. That's when the cartilage is completely gone and the bones of the joints are rubbing against each other without cartilage, which, as you can imagine, would be very, very painful. From a biomechanical perspective, this also causes a change in the transfer of forces across the joint. And this excess transfer of force to the bone will produce some of the changes that we see on imaging that I will review with you. This picture on the right is really a three-dimensional animation representation of what arthritis can start to look like as the cartilage breaks down. Compared to the image on the left, you can see that the cartilage is irregular. Those nice shiny white surfaces on the left are now irregular. They look a little bumpy, which is supposed to represent bone spurs, which we'll review. It also looks very red and inflamed, which represents the inflammatory pain that arthritis can produce. Within the general category of shoulder arthritis, there are a number of things that can actually cause arthritis. By far, the most common form is what we call primary osteoarthritis, which refers to wear and tear over time, meaning as you've used your arm over the year, whether for work or for leisure, that nice, shiny, bright, white, smooth cartilage surface is starting to wear down and transition to more of an arthritic surface. The second most frequent cause of shoulder arthritis is what we refer to as post-traumatic arthritis. And that can happen for two reasons, primarily. One would be if you dislocated your shoulder, meaning the ball of the shoulder popped out of the socket, and usually that requires someone like an emergency room physician putting the ball back in. It's a very unpleasant experience I hope no one has to go through. But we know from our research that even having one dislocation of the shoulder predisposes you to further development of arthritis down the road. So even if you dislocate your shoulder as a football player when you're a teenager, you are at risk for development of early shoulder arthritis down the road. The second piece of the puzzle from the post-traumatic arthritis perspective is if you have a break or fracture within the joint surfaces we've described. So if you break the ball or break the socket, what can happen is that nice, perfectly smooth surface can start to develop a little bit of step off or irregularity. Now, again, that will not cause immediate onset of arthritis, but that can cause a change in the transfer of forces across that joint with time. The third form of arthritis in the shoulder that we see is what we call inflammatory arthritis. And again, this is really a general category for things like rheumatoid arthritis, gout, any type of autoimmune process that could be contributing to your body attacking your own cells. That's what autoimmune refers to. So what can happen in the shoulder is this generalized autoimmune process throughout your body doesn't recognize cells as your own, and your body starts to attack and break them down in the shoulder and other joints in the body. That can result in eating away that cartilage and having arthritis. The next type of arthritis, which is less common, is something called avascular necrosis. It's a fancy term for basically describing that you have lost blood supply to the bone. This very, very, very rarely affects the socket side of the shoulder, but it can affect the ball side. There are a number of things that can cause this. Trauma or injury can cause it if it's a very severe trauma. Other things that can cause it are if you've been on high-dose oral steroids for things. Again, this could be happening even when you're a teenager. Probably one of the most frequent reasons that people are on high-dose steroids when they're younger is for asthma, a breathing disorder. And you can have development of injury to the blood supply to the bone. And what happens when that occurs is the bone actually starts to die. It's a slow process, and it's generally not bothersome to people until the dead bone then also collapses. That again creates an irregular surface along the joint, so we don't have a perfectly round ball. Other common causes of avascular necrosis are certain types of chemotherapy for cancer treatment, and less rarely, but occasionally, it's radiation therapy for cancer treatment. I unfortunately have seen this from breast cancer survivors who've undergone one or both of those treatments. So it's always something I'm looking out for on imaging and is not necessarily readily visible on X-ray. The last type of arthritis is a slightly different form, and that's why I highlighted it in red. This form of arthritis is referred to as rotator cuff arthropathy. So we talked a little bit about the rotator cuff in previous slides. Again, that set of 4 muscles that contributes to shoulder motion. The other way the rotator cuff contributes to function is it actually holds the ball of the shoulder down in the socket. When you've had a chronic or long-term rotator cuff tear, that mechanical control of the ball is lost and the ball starts to shift up. That also can cause an abnormal transfer of forces through the joint itself and produces a specific wear pattern or arthritic pattern that we see in people who have had chronic rotator cuff failure. And I highlighted that in red because we're going to look at the unique imaging findings and unique surgical options for people with rotator cuff arthropathy. So, how does arthritis impact the shoulder in particular? I'm sure you all have had friends who've had knee and hip arthritis. I always tell people it's more common than shoulder arthritis because most of us don't walk on our hands. And the reason that that becomes relevant is I feel like in the office, I see people who present or show up with much more advanced arthritis than they show up for, say, more mild or moderate knee or hip arthritis. And I really do think that's because you're not repetitively walking on your shoulder every day, and you're able to easily modify a lot of the weight bearing or lifting activities that the shoulder is responsible for. So when we talk about how to measure shoulder arthritis, when we speak about the severity, there are really 4 components of arthritis that I'm looking for, particularly on X-ray. Those would include joint space narrowing, and we'll describe what that means, osteophytes or bone spur formation, sclerosis, which refers to hardening of the bone, and cyst formation. If we look at the X-ray, which is this 2-dimensional image at the top right of your screen with lots of things outlined, we'll go one by one. So the joint space narrowing refers to the ball being closer to the socket than we should see on X-ray. X-ray is a great two-dimensional imaging study that provides me information both about bones, but also the relationship between bones. There's a very standard normal distance that I should expect to see between the ball and the socket. That's about 5 millimeters. As that starts to get tighter and tighter on an X-ray, I say, okay, we're having some joint space narrowing, maybe development of early arthritis. That's probably the most common and first sign of arthritis. The next one, bone spur formation or osteophyte formation, is very common in shoulder arthritis. You can see that depicted here with the term osteophyte and the outlines in red. What that refers to is extra bone formations. One of the body's responses to arthritis and that extra force being transferred through the bone is to actually build extra bone. So you'll get these extra bones growing around the ball and socket joint that can contribute to loss of range of motion, catching or popping sensations, and it's a very common presentation of arthritis. The next type of contribution to the X-ray that we see from more advanced arthritis is something called sclerosis. Sclerosis refers to the hardening of the bone, and one thing that the bone does in response to receiving increased force once the cartilage is gone is gets harder and denser to try to absorb that force in a more comfortable manner. So sclerosis on X-ray shows me areas where the bone is more dense than I would expect to see. The last thing that arthritis can do in the shoulder is form something called a cyst. And a cyst is actually a weak point behind the really hard sclerotic bone that can occur from repetitive, again, wear and tear over that joint to the point where your bone, usually a little bit farther away from the joint, actually, if you look at this picture, it's not right along the ball and socket surface, can start to kind of break down a little bit. So we see changes overall to the bony architecture in varying degrees. The other thing that we can start to see with more severe arthritis is what I refer to as deformity. If we look at this X-ray on the bottom left, that's labeled glenoid. Glenoid again refers to the socket. You see that red line going through the X-ray. That red line should really form a T or a perpendicular line with your socket. In this case, you can see it's angled more like this, which refers to the socket has not been wearing away in an even pattern. This is common, very common with advanced arthritis, that we preferentially wear out the posterior or back part of the shoulder joint. What we see on the bottom right X-ray is unique to rotator cuff arthropathy that I described before, and you can see that that ball is now not centered in the socket. It's shifted up and riding on the shelf of bone on top, which we refer to as the acromion. We'll see more pictures of that, and I'll explain that again later because that concept is, again, more complicated and unique to the form of arthritis called rotator cuff arthropathy. So how does shoulder arthritis feel? Again, when we walk on our knees and hips and have arthritis, it becomes pretty clear that every step you take hurts. But again, we don't walk on our shoulders. So when I hear people complaining and describing the issues they're experiencing when I see them in the office, there are really three things that stick out to me, even if I haven't seen an image or X-ray, that make my ears prick up to be concerned for arthritis. One is a deep, constant, aching pain that is not necessarily dependent on if you're moving the shoulder or not. So if you have really chronic, constant pain that's occurring even at rest when you're sitting, reading a book or watching TV, that can be concerning for arthritic development. The second thing that's very common in shoulder arthritis, but honestly is present in a lot of shoulder abnormalities, is night pain. So difficulty sleeping, particularly on the side that's affected, but some people still have persistent night pain despite not sleeping on their symptomatic shoulder. The third thing, which is pretty specific for arthritis as well, is something called loss of range of motion. So we reviewed at the beginning that the shoulder is the most mobile joint in the body. Its range of motion is pretty dramatic, and when you start to lose a certain degree of range of motion, patients can start to struggle with things like reaching up to get a sweater, putting away a dish or cup. Things that require this combined, kind of more extreme motion can become more challenging for people. Also, reaching behind your back or in the back seat of the car can become very challenging. The pattern of symptoms in shoulder arthritis is also unique. It's a very slow onset. So this aching pain I described, you may notice it minimally for the first, say, few months, and even notice that you're okay at rest, but when you're doing activity, you notice it gets worse. Then what can happen is it will become more consistent and more constant and start to aggravate you even when you're not doing anything. The symptoms, again, at the beginning, more frequently than toward the end, are usually related to what we refer to as overuse or can be dependent on your profession. I included a picture here of an electrician because unfortunately their job is very demanding on their shoulders, working overhead frequently and oftentimes with weight as well. And that can be very, very challenging on the shoulder in the long term. That being said, things like overuse, what that refers to would even be something like the first time you weed the yard, especially this year with all the rain. Doing something repetitively that your body is not necessarily accustomed to can start to unveil or produce these arthritic symptoms. The other thing could be when we refer to things as being activity dependent, that would be, let's say you're an avid golfer and you start to notice that you're okay when you go to the driving range, but when you do 9 holes, it hurts a little bit. When you do 18 holes, you're miserable, and you're starting to kind of subconsciously cut back on the degree of activity that you're doing. And then the last would be related to some of those post-traumatic injuries I described, but development of pain, loss of range of motion after you've had an injury. And again, that time frame from the injury is variable. I've had patients who were seen in high school, didn't see anyone for 60 years, and showed up for their first evaluation with severe arthritis. So it can be a broad spectrum of how long it can take to develop arthritis after an injury. After I've kind of reviewed your options and described some of your symptom patterns in the office, I'll always do a physical exam. And what I first test in this exam is I'll actually just look at your shoulders and see if you have any deformity, particularly if it's residual deformity from a prior injury. It also shows me the contours of your muscles, which can give me clues about what could be contributing. And on this physical exam, what's most common in people with shoulder arthritis is a loss of range of motion, which is depicted here in these images on the right. What you see here is a woman facing forward, having her left shoulder evaluated. And this is a specific type of range of motion. This is what we call passive range of motion, meaning this physician in the picture is moving her arm for her. She's not actively moving it itself. And even when he is moving her arm for her, her arc of motion is very limited, meaning she can only rotate her arm to here. She can only lift it up to about here. So that's a very indicative sign of loss of range of motion. If you passively, meaning someone else doing it for you, you still cannot move your arm. Interestingly, people often have normal strength. The most common pattern of arthritis, primary osteoarthritis, usually involves having an intact or functional rotator cuff. And they seem to be pretty often, it's either one or the other. You either tear your rotator cuff, which we're not talking about much today, or you can develop arthritis. So oftentimes when I do a physical exam, people's strength is actually very good. And you notice if we go back to this prior slide, one of the common symptoms that we review is not weakness. So weakness is less common for shoulder arthritis than the other things we've described. The last thing that I often see in people with more advanced or limiting arthritis is what I refer to as compensatory pain, frequently along the back of their shoulder blade and again up into their neck. That's where, when we review those slides with pictures of the larger muscles attaching to the shoulder and shoulder blade, that's why those are so important. They start to work overtime when your shoulder can't move the way it's supposed to. Our shoulder blade is actually responsible for 1/3 of our shoulder motion. So if the shoulder joint, meaning the glenohumeral deep joint, is so limited that you can't get the expected range of motion from that joint, then your shoulder blade or scapula performs excessive motion and causes those muscles to get tired, sore, and tight. Also in the office, you're welcome to bring x-rays if you've had them previously. We have multiple x-ray machines in our office, so if you show up without x-rays, I'll always recommend that we get x-rays. Also, if you've had x-rays in the past, if they're a little bit outdated, it's helpful to have updated x-rays generally within the last 6 months. So we often obtain x-rays in our office to evaluate the degree of arthritis or other abnormalities if they're present. This x-ray I wanted to show, we had that prior x-ray that showed the cysts and the osteophytes and the joint space narrowing that was labeled. Now this is an example of that without the label. So you can see how dramatic that joint space narrowing can be. And on this image in particular, if you follow the contour of the arm bone or humerus, you can see that big ball kind of under the bottom of the shoulder joint, and that's a big bone spur. So this will give me a good sense of what we're working with and if there's any significant deformity that I need to be concerned about. Findings on physical exam that are specific to rotator cuff arthropathy. And again, rotator cuff arthropathy is the type of arthritis that you develop.
Emergency room 12.
Just a minute.
Stroke alert activation. Emergency room 12. Now.
Rotator cuff arthropathy is the type of arthritis that develops with a chronic rotator cuff tear where the forces are starting to transfer differently through the joint and the ball is starting to slide up out of the socket. On physical exam, what I see is I actually look at the back of the shoulder. And what this will depict is atrophy or disintegration, to be a little dramatic, of the rotator cuff muscles on the back not being present. Just a minute, sorry.
Stroke alert activation. Emergency room 12 now. Stroke alert activation. Emergency room 12 now.
If we look at this picture on the right, you can see how bony this gentleman appears along the back of the shoulder blade. And he is thin, but the reason that those bones look so prominent is because the muscles surrounding them have deteriorated. The other thing we see on physical exam is something called pseudoparalysis, which is a fancy term for saying that the motion is limited in all planes and they truly cannot move their arm, but they're usually not stiff to the passive range of motion I showed you before. So patients with rotator cuff arthropathy and this pseudoparalysis won't be able to lift up. But if I take their arm, I am able to lift their arm up, meaning they don't have this strict bony block to motion that we see in primary osteoarthritis. So now I want to move on to what we do when we've established that you have some spectrum of shoulder arthritis. And I always think from a minimally invasive option at the beginning. I always think from least to most invasive. And what I always tell people with shoulder arthritis is option one is you don't have to do anything for it. So if you come in and we find out you have shoulder arthritis, but your function and pain level is satisfactory to you, we never have to do anything. My next step, if we start working up the ladder from least to most invasive, would be physical therapy. And I found that this is the most successful for people with mild to moderate arthritis based on their x-rays, meaning that they're not bone on bone yet. They don't have these crazy massive bone spurs that are truly providing a block to motion. The goals of physical therapy would be to improve your range of motion with a physical therapist. There are multiple what we refer to as modalities in physical therapy that can help with this. I really think of physical therapy as two arms. One arm is what can the therapist do for you when you're in the office that you can't do for yourself at home. That would include things like stretching, electrical stimulation, something called dry needling, which can help release muscle tightness. The other option or arm of therapy is exercise. And that part of the therapy visit involves learning exercises that you then go and take home and do at home on a daily basis. So you get homework from physical therapy. And the most important part of the long-term outcome of physical therapy will be maintaining the range of motion exercises and strength exercises they give you. But having the therapy in the office to do this manual component of therapy can help you get there more easily. So apart from improving range of motion, therapy definitely helps contribute to decreasing pain and dysfunction, particularly again along the shoulder blade or scapula. And lastly, physical therapy can optimize the muscular strength surrounding the shoulder. When we start thinking about other options that are still relatively non-invasive, I think of medication management. Again, I found that this is most successful for people with mild to moderate arthritis. In this case, the goals would include decreasing inflammatory pain and improving sleep. To decrease inflammatory pain, I often prescribe what's referred to as a non-steroidal anti-inflammatory or recommend an over-the-counter version. The over-the-counter versions of those would include things like Advil, Aleve, ibuprofen, Motrin, that general family of medication. Tylenol is not in that family, but the other common over-the-counter names are anti-inflammatories. I'm always happy to review which one might be best for you or give you a prescription if that's simpler or easier. Additionally, particularly in people who are really struggling to sleep at night, I found that a muscle relaxant is very helpful. I generally only prescribe it to take before bedtime and not to take throughout the day. It's helpful because it lets you relax a little bit, but it also helps all those tight muscles surrounding the shoulder joint relax and take a break. The next form of treatment, we start to get into a little bit of an invasive measure, which is in the form of an injection. And I think within the injection family, the goal is to provide benefit to really arthritis of all severities. So if you remember the first two options, the medication and the therapy I mentioned, I really start with that for mild to moderate arthritis. If you come into my office and you already have really bad arthritis, sometimes we'll jump to this as a first step. And within the injection family, there are really three options. Only one of those three, unfortunately, is covered by insurance, and I'll review the costs of the other two. So a corticosteroid injection is an injectable form of an anti-inflammatory. And so again, that would help with the inflammatory pain that's reduced or caused from arthritis. The biggest benefit of that would be if we can get your pain under control, then hopefully all these other symptoms you're experiencing, loss of range of motion, pain along your shoulder blade and up into your neck can improve. It can also be utilized to decrease someone's pain so that they are well enough managed to even participate in physical therapy. The next injection is something called hyaluronic acid. It's actually FDA approved and covered by most insurances for knee arthritis. It's not covered by insurance for any other arthritic joint in the body, which is a shame because I've had really, really good luck with it functioning as a mechanical lubricant for people with, say, mild to moderate arthritis as a first line of treatment, or if we're in severe arthritis with a patient who either can't have surgery or really doesn't want to have surgery. And I tell people it's like WD-40. So it has a combination of effects. One is it's an actual gel injection, so it has a tiny bit of a shock absorption component to it. But I also think that it helps so much with this mechanical pain because it kind of fills in these irregularities and coats the joint so that we're not having these rough, uneven surfaces rub against each other. The last option is something called platelet-rich plasma. This is the only one of the three options that has the propensity or ability to actually improve the environment of the cartilage damage in the shoulder. Now, the world of biologic injections in the shoulder is still very new, to be honest. We're not able in our country to manipulate cellular products from our body to the same degree that people in other countries are. But that being said, I've kind of reviewed what PRP entails on this image on the right. So what it involves is coming into the office for an appointment. There's no anesthesia required. We draw your blood, 2 vials of your blood, spin it down in something that's referred to as a centrifuge. And all that does is it separates the cells in the blood based on weight. We remove the red blood cells, we don't need those for this, and you end up getting this concentrate of plasma, which has the healing properties of the blood, in a concentrated form, and those are then injected into the shoulder. The goal would be, again, that they can start to kind of attack and heal in these abnormal cartilage surfaces. This, again, the best research is for mild to moderate arthritis. So this is an option. This one is about $700. The hyaluronic acid injection is approximately $150. So we've talked about things that are primarily non-invasive or minimally invasive. When do you need to do more for this? So what I generally describe to people is if you've had persistent pain or dysfunction without improvement from the things we've previously described. A decline in function is another reason, meaning the first time I met you, you were doing okay, you tried these things, but you're actually getting worse. That could be worsening range of motion, worsening sleep, and inability to perform daily tasks. A thing I frequently hear is people can't wash their hair. Women can't fasten their bras. They have a difficult time sometimes even brushing their teeth or eating. When you start to get into limitation of tasks like that, this becomes something that is pretty debilitating, and people are interested in doing more for their shoulder arthritis. So now we're going to talk about a couple of non-shoulder replacement procedural options, okay? The first one is something that's developed really in the last 10 years. It's called Comprehensive Arthroscopic Management. Its acronym is CAM, so we refer to it as the CAM procedure. And what it is a minimally invasive arthroscopic procedure to address both the mechanical and inflammatory pain that's produced from arthritis. Okay, great. What does this do? It removes the inflammatory tissue, particularly the joint lining, loose pieces of cartilage or bone floating around in the joint, and occasionally even has the ability to remove bone spurs that have formed along the joint borders. I release the joint capsule during that procedure. So one thing we haven't talked about is the ball and socket joint has a soft tissue layer over it that we refer to as the capsule that can get thickened and tightened in arthritis. And in this procedure, that's released so that you can have more range of motion. By releasing the capsule and removing some of these bone spurs, we can also release some of the irritation along nerves that kind of run through your armpit or axilla, and that can improve people's symptoms as well. The last thing that people often have with shoulder arthritis is concomitant or additional bicep tendon pain. They go together very often, and this procedure can also address the bicep tendon dysfunction in addition to the arthritic components of the shoulder. What are really the goals? It's not a perfect procedure for most people. The main thing it can do is prevent the need for joint replacement for up to 5 years in the research. And you say, well, that's not very impressive. If you're a 40-year-old electrician, that's a big difference. If we can buy you 5 years and start talking about providing you the ability to avoid a joint replacement when you're that young, that becomes pretty important. It also allows young people who have a very high physical demand at their job to be able to continue to do their job. The last option and other appealing component of it is it's an arthroscopic, minimally invasive surgery with essentially no downtime. So you're able to move right away. We'll talk about that on this next slide in a minute. This is an animation of what the procedure entails. So on the left in this picture, you see the arthroscopic camera going in the back of the shoulder. And on the right, you see an arthroscopic instrument referred to as a shaver. So you really only have 2 to 3 1-centimeter incisions to do this work. One is for the camera, and the other 1 to 2 incisions are for our instruments. And they remove both soft tissue inflammation, again, as mechanical, meaning cartilage or bone pieces that are floating around causing problems. I started talking about the recovery from this. I got ahead of myself. So this postoperative course is pretty minimal, to be honest. You're in a sling as needed. You progress range of motion and activity as tolerated. I do have you do physical therapy after the procedure, starting around 2 weeks after surgery, to work on regaining range of motion and engaging muscle groups that you may not have been able to in the past because you were so stiff. A full recovery for something like this, to say get back to golf, tennis, etc., is about 3 to 6 months. Another newer procedure that we offer in our office through one of our physicians who is a physiatrist, so a non-surgical expert, is something called shoulder joint sensory nerve ablation. And this picture on the right, I know is very complicated, but what I want you to focus on the picture on the right is all of the yellow structures. Those are nerve endings. And what that picture is depicting is that we have these tiny nerve endings that go to the joint. And what they do is when the joint hurts, they send signals to your brain to interpret as pain. It sounds really simple. Nerves are electrical circuits, essentially. And so you have this electrical circuit going from your painful arthritic shoulder joint to your brain that then turns into this sensation of pain. And so the goal of this procedure is to kind of halt or stop that electrical signal going back to your brain, not of the nerves that control the muscle function or motion of the shoulder, but just the sensory feedback to your brain. What the procedure is called is an ablation procedure, which refers to, again, stopping those nerves from functioning and sending the pain signals to your brain. And the goal is to improve pain and ultimately, hopefully, also allow an improved range of motion. When is this the right option? It's appropriate for people with arthritic pain who've done everything else we've talked about. It's also appropriate when medical conditions, meaning heart, lung, kidney, preclude you or prevent you from being able to have surgery as a safe option. It's also a great option if people don't have the time or ability to take time away to have surgery. I've had multiple patients who are the primary caregivers for their spouses or partners, and they can't take the recovery time that's necessary from a shoulder replacement to take care of their pain. So this is a newer option that we do offer in our office. Again, no anesthesia provided for most patients, but it can be very helpful. Okay. The last section, which you probably all have been waiting for, but I actually think is the most obvious of everything we've discussed, is total shoulder replacement. This involves surgically replacing the abnormal surfaces that have been worn away by arthritis. It's an appropriate option for most patients with moderate to severe osteoarthritis or other forms of arthritis that have had a lack of improvement from the other treatments we've described, and even including those less invasive procedures. So there are two types of shoulder replacements, and I want us to look at these here. The one on the top is the most frequently performed. This is what's referred to as an anatomic total shoulder replacement. You must have an intact rotator cuff for this to be a good option for you and for you to have a good outcome. And we call it anatomic because we are replacing your native ball of the humerus with a metal ball, and we're replacing your native glenoid or socket with a plastic socket. The bottom option, which is called a reverse total shoulder replacement, is a great option for people with, and really the only option for people with rotator cuff arthropathy. So again, that pattern of arthritis that's developed from chronic rotator cuff failure. Additionally, it's a great option for people who have really severe deformity or are having this surgery from having a prior fracture or break in the arm. That usually, if they get to this point, does produce deformity as well. So these are the two options. In the reverse option, if you look at where the socket normally is, you'll notice, wow, there's a metal ball there. That's why it's called a reverse. You replace the socket with a ball and the ball with a socket. So the center of rotation of the shoulder is shifted and no longer dependent on your rotator cuff for function. We're going to look at imaging planning for total shoulder replacements. This is an actual patient of mine. So again, the X-ray is a two-dimensional picture that provides bony information about arthritis that we can obtain during your visit, or you can come to our office with it. But on this picture, again, you see that ball in that socket, and there is no space between the ball and the socket. We look at the image on the right, which is called the axillary image, where the elbow is out to the side, and we see the socket from a different perspective. In that picture, we can see that there's, again, redemonstration of bone-on-bone arthritis and some deformity. When I see this picture and I've counseled the patient about their options, we ultimately, with this patient, elected to proceed with total shoulder replacement planning. My next step is to get more advanced imaging, and that really is usually two additional studies. One is an MRI. An MRI provides, and this is the same patient, an MRI provides me three-dimensional information about the surrounding soft tissue structures, specifically the rotator cuff. So in this image, I'm not going to go into too much detail, but I can tell from this image that the patient has an intact rotator cuff, which is important for letting me know that it's safe to proceed with the anatomic shoulder replacement. Lastly, we'll also have you obtain a CAT scan in most scenarios, which gives me three-dimensional bony information that allows me to plan your implants before surgery so that when I go into surgery, I know exactly which size ball you need and which size socket you need. It makes the surgery more efficient. And this is an example of the modeling I can do based on that CAT scan. So this is a depiction only of the scapula or shoulder blade with the socket. It's like you removed the whole humerus or arm bone. And this allows me in the software, I can rotate the implant, I can test out the different sizes and make sure that the trajectory of the implant and the size of the implant is best for you. And I do all of this before every joint replacement surgery. And then again, here's a picture of a post-operative x-ray, I should say, of a patient who's had a total shoulder replacement. There are actually two types of anatomic total shoulder replacements on the stem side. So if you look at this humerus side, you can see that big bright white stem going up the humerus with a ball. That's what we call a stemmed shoulder replacement. If we go to this next slide, a lot of companies are moving toward a less invasive ball side on the humerus and a form what we call stemless. This has been a really great option in our community here in Boulder. People are so active and really have excellent bone quality that this is a great option to add fixation to the bone without having to put that stem all the way down the bone marrow or canal of the humerus. Next, I wanted to again review how the reverse total shoulder imaging is slightly different and how that affects our planning. So again, on the left, we see that migration of the humeral head up and out of the socket. And I added this picture on the right to show you what a normal distance is and how you can see the ball centered in the socket. So again, on the left picture, you can see the ball's coming up out of the socket, and on the right, you can see it's nice and centered. This is what an MRI of someone who needs a reverse total shoulder replacement will look like. What you see is all this area on the MRI that's white essentially represents area where the rotator cuff is gone. And I'm going to be pretty simple here because that can be a much more complex conversation. And then this last picture is an example of a reverse total shoulder replacement. I showed this before, but just wanted to reiterate how the socket is now a ball and the ball is now a socket. What's the recovery like from a total shoulder replacement? I tell people it's long and boring. I have you in a sling after surgery for 4 to 6 weeks. I again have you start physical therapy 2 weeks after surgery. At that 6-week mark, we'll see you in the office, take an x-ray, get you out of your sling, and then you do not have any motion restrictions that I impose upon you. You're still progressing your range of motion, but you don't have to worry about how you move your arm. But from 6 to 12 weeks after surgery, you cannot lift more than 1 pound. Ultimately, your range of motion and activity progresses incrementally, and then full recovery from this can vary anywhere from 6 to 12 months. There is actually good research that shows that you can continue to see improvement from these surgeries up to 2 years after surgery. So it's not a short process. Fortunately, for most people, it's not a particularly painful recovery. It actually seems to be less painful in most patients than, for instance, repairing the rotator cuff, which is an arthroscopic procedure I also perform. Lastly, when we think about long-term results of total shoulder replacement, I wanted to focus on the two things that people really ask me about. One is long-term restrictions. There are none. Historically, including even when I started my practice, I used to limit people's repetitive weightlifting to 25 pounds. And that's for people who say they want to go to the gym and lift heavy every single day. We used to say no. I still don't love if that's what you choose to do with your brand new shoulder, but there's not research anymore to support that heavy lifting is going to cause loosening of the components from the bone. Additionally, we talk about the lifespan of these implants, and the simplest way to think about it is on average, there's a 1% failure rate per year. So that means at 10 years, there's a 10% chance that your implants will have failed and you'll need another surgery. And at 20 years, there's a 20% chance that you'll need a second surgery. Those are pretty small percentages. So I really try to get you to an age where we're not going to have to do this in 20 years. 20 years is really my metric. So I mentioned earlier, someone having a shoulder replacement at 45 is not a super ideal option. I do have patients where I've done shoulder replacements that young, but I tell them you will probably need another surgery in your life. And they understand that process, but that's something we work through and speak through. So again, just to review everything we talked about relevant shoulder anatomy. We reviewed the natural process of cartilage breakdown or shoulder or arthritis. We specifically talked about how arthritis can affect the shoulder. We talked about non-invasive options for the shoulder. We talked about procedural options, including arthroscopic and nerve ablating or stopping options. And lastly, talked about the total shoulder replacement. Thank you very much.
Thank you, Dr. Mayo. That was very informational. And we do have some questions to send your way, and want to remind our audience that now is the time to submit your questions in the chat, and we'll get to as many as we can.
Okay.
For this person, they said, please remind me, does a separated shoulder with AC joint injury, does that lead to arthritis like a dislocated shoulder can?
That's a great question. And this is something we see frequently in the office. So I'm going to try to go back to a picture, but if not, we can reference, you guys can go back and reference some of the photos I showed earlier in the presentation. The AC joint or acromioclavicular joint is a tiny dime-sized joint where your collarbone meets your shoulder blade. It is not your shoulder joint. So when people say they've separated their shoulder, that's actually a very different thing than dislocating your shoulder. AC joint separation does not necessarily just predispose you or make you at risk for developing glenohumeral or shoulder arthritis. I wish that people didn't refer to it, including physicians and providers, as separating your shoulder, because it is very confusing, but it is not actually your shoulder joint.
Okay, thank you for that clarification. If you hear or feel clicking when you move your shoulder around, is that indicating bone hitting bone, or is it something else?
More often than not, clicking is actually soft tissue structures that are deep in the shoulder catching a little bit. It can be associated with arthritis. What I usually tell people is non-painful clicking or popping is nothing to be concerned about. When you start to develop pain associated with the clicking or popping, that's when you should probably be evaluated.
Is shoulder arthritis hereditary?
That's a great question. So in general, no. I would say that we have not, as orthopedic surgeons, been able to identify a specific genetic marker for hereditary forms of arthritis. That being said, there is definitely some genetic form out there that we haven't identified. I've had patients who've had both knees, both hips, both shoulders replaced, and their mom had the same thing, their sister has the same thing. So there definitely is a hereditary pattern. That is pretty rare. Usually, again, the most common form of arthritis is primary wear and tear osteoarthritis. The one kind of caveat or exception to that would be the inflammatory or autoimmune pattern of arthritis. Those patients very frequently have a family history of autoimmune disease, like rheumatoid arthritis being the most common. And even if your mom or sister or grandma had rheumatoid arthritis and it didn't affect your shoulder, I still will ask people, particularly if they present when they're younger with shoulder arthritis, if they have had a family history of autoimmune diseases like rheumatoid arthritis.
Okay. Which muscle relaxers do you like to prescribe for patients with mild shoulder arthritis?
That's a great question. I always tell patients, if you have one that you like or you prefer, that's great. And I'm happy to prescribe any of the muscle relaxant family. They all function fairly similarly. There are two options I stick to the most. One is cyclobenzaprine is the generic name. The proprietary name is Flexeril. That one's probably the most frequently prescribed, I should say. And that one, again, I only prescribe before bedtime. It's difficult to take during the day because it can make things a little too relaxed during the day. It can have side effects of making people feel a little bit lightheaded. So if you're prone to feeling lightheaded or have known low blood pressure at baseline, it may not be the best option. One that has slightly fewer side effects but isn't, in my opinion, quite as strong as something called methocarbamol is the generic name. The proprietary name is Roboxin. And that one's becoming much more frequently prescribed because, again, that side effect profile is much more mild. So we talk about that in the office and determine what would be best for you.
Kind of a segue to that, can you recommend what active ingredients to look for in an all-natural muscle relaxer?
That's a great question. From a muscle relaxant perspective, I mean, magnesium can be helpful. So magnesium supplementation can be helpful. Most people, when they're in the naturopathic category, I tend to talk with people about anti-inflammatory components. Things like turmeric can be very helpful to avoid inflammation. Also, that's really the main one that has true anti-inflammatory components to it. That's the one that I would focus on. But the magnesium is a simple supplement that you can take to help with muscle relaxation as well.
Okay, thank you. Is swimming good for treating arthritis by keeping the shoulder moving and working the muscles, or is it just making arthritis worse and should be avoided?
Swimming is a tough one. My swimmers are really passionate people about swimming. So I always tell people, if you have shoulder arthritis and you're a swimmer, it certainly can aggravate arthritis, particularly because you are forced to put your arm in these really maximal end ranges of motion, particularly if you're either doing freestyle or backstroke or fly. So if I have swimmers who say, I love doing freestyle, but I just can't, you may find that tolerating breaststroke is much easier. Breaststroke doesn't require that real overhead motion to the same degree at all. So I try to encourage people to do breaststroke. If they say, no, I have to do freestyle or I'm going to be depressed for the rest of my life, then I say, you're welcome to do that, but don't be surprised if it aggravates your shoulder. It should not, to be honest, cause rapid progression of existing arthritis. It's just not well tolerated.
What does it mean to have a frozen shoulder?
That's a great question that we honestly didn't really talk about because it's kind of opening a can of worms. What a frozen shoulder is someone who has a normal cartilage surface, meaning the ball and socket are normal, and surrounding that cartilage surface, that joint capsule that I described gets very inflamed and thickened. So the bone structure's fine, the muscle's fine, but that capsule gets really thickened and tightened and starts to clamp down to the point where you can't move your arm. The best thing about shoulder arthritis is it ultimately goes away in time without surgery in about 95% of people, if not more than that.
So do you have a recommendation on how to help that heal?
It's pretty similar to the kind of initial conservative treatment stages of shoulder arthritis. So I think physical therapy in a kind of restricted manner can be helpful for frozen shoulder. Additionally, anti-inflammatories are very helpful for helping the inflammatory pain. The anti-inflammatories do not accelerate the recovery process, but they make it more tolerable as your body's going through it. And again, muscle relaxants can also be very helpful for the surrounding muscles that get irritated from the frozen shoulder.
Okay. Just a few more questions here, and then we'll wrap it up for our audience. Is whole arm pain common with an arthritic shoulder?
That's a great question. No would be my short answer. So it's very, very common for shoulder pain to do what we call refer, meaning go somewhere else, to the level of the elbow and also up to the neck. When people are experiencing pain throughout their whole arm, that is much more frequently associated with pinched or damaged nerves coming from your neck.
Okay. For mild shoulder pain, do you recommend using ice or heat or a combination?
For shoulder pain without arthritis, or an unknown arthritis, I guess we're saying. Generally, what I tell people is if you find that a component of your shoulder discomfort is tightness, I recommend doing heat before you do activity or before you do stretching or working out in the gym, and ice immediately after. Ice will help get down any inflammation that you've built up from your activity.
What are your thoughts about stem cell treatment?
It's a great question, one that I didn't bring up kind of on purpose. So I mentioned when I was talking about the biologics in my talk that the FDA really limits what we can do with cells. I think there's a lot of future promise for stem cells and other cellular manipulations, but the challenge is that the stem cell concentrations that we can get within FDA regulation are very dilute compared to a lot of the stem cell studies that are either performed in trials or performed in other countries. So I don't think we have the ability to concentrate the stem cells to the same degree that we can in other countries. The other issue with stem cells, what stem cells are naive young cells that basically can do either lots of things or anything. And the challenge with stem cells is you can't direct them which path they're going to go. So they may go down the healing path, they may go down another path. We don't have the same control over the stem cell, in my opinion, as we do the platelet-rich plasma, which we know exactly what properties are in it and what those properties can do.
Could the injections provide relief for neck arthritis?
That's a great question. So if we determine, and unfortunately there are people who have both neck and shoulder arthritis, which can be really debilitating. For people with neck arthritis, depending on how that is causing you symptoms, there are injections that can provide you relief. And we provide those in our office as well. So I oftentimes will see a patient who thinks they have horrible shoulder arthritis. We get an x-ray, it looks pretty good. Sometimes even get an MRI just to make sure. And then we get imaging of their neck and it's pretty dramatically arthritic. Oftentimes with those patients, I'll have them tackle the neck first, since that seems like the bigger area that could be contributing. And we have physicians in our office who can do those neck injections and neck evaluation as well.
All right, a couple more questions here and then we'll wrap it up. You had mentioned the 10-year and the 20-year lifespan for surgery. And so is there a limit on age? Say you're in your 80s, even 90s, and you have your rotator cuff arthropathy.
Yep.
Arthropathy. Would that be like, well,
No.
sorry you don't have so much pain, but you know you're too old. We can't do this.
Age is a number to me. Unfortunately, as we get older, we can develop more significant medical problems. So I actually don't care about someone's age at all. I do care about their medical problems and if it's safe for them to have surgery. I also care about their level of function. So if you have a horrible shoulder on imaging, but you're not super active or don't need your arm to maintain your current level of independence, the benefit of the surgery may not really outweigh the risk. Alternatively, I've had multiple patients in their 90s I've done these surgeries on who've been very happy with their outcome, and it's allowed them to stay independent and doing what they want to do.
Does insurance cover this?
It does.
Okay.
I'll elaborate on that. So insurance does cover it. If you're under the age of 65 and not on any type of Medicare or Medicare replacement plan, we have the ability to do this on a purely outpatient basis at our surgery center. Alternatively, if you have Medicare or Medicare replacement plan, we are required to do it in what's referred to as an inpatient facility, like a hospital. That being said, even if you have your surgery at the hospital and you want to go home the same day, you certainly can. I would say of my patients who have surgery in the hospital, about 60% go home the same day and 40% stay one night, and almost every single one goes home the next day.
Can you take cyclobenzaprine with ibuprofen and or Tylenol?
Yes, so that's one reason I like those medicines is they're all processed slightly differently in your body. So actually Tylenol, any anti-inflammatory, and cyclobenzaprine are all safe to take together.
Okay, and PMR, what is the treatment? Pain is 10-10 after oral steroids for a year.
I'm assuming this person's speaking about something called polymyalgia rheumatica, which is a very unfortunate diagnosis to have. It's not something that's usually, I should say, related to a joint arthritis as well. It's often related to muscular pain and the feedback your brain gets from that pain. It's almost like having a hypersensitive nerve, meaning the pain is super, super severe. Options for that can be helpful. It's kind of completely independent of this talk, but I do find that the manual side of physical therapy can really help PMR. The other thing that can be helpful is doing trigger point injections, which we could do in our office, or even potentially doing the needling procedure I described with physical therapy. Oftentimes, though, these patients do end up requiring outside medication management, either from their primary care doctor or potentially a rheumatologist.
Thank you so much for taking all of these
Thank you.
questions.